Marylyn McEwen, a member of the Public Health Nursing Section, and today I'm going to tell you a little bit about the research that I'm involved with. I was fortunate enough to get a proposal funded that I submitted as an R01 to NIH, Minority Health and Health Disparities. And it was funded for 5 years. We're just starting. This is February 2013. We're just getting into year 3 of the study. So I'll tell you a little bit about the background. Diabetes has reached epidemic proportions globally, but the focus of my research is in the U.S.-Mexico border region. And the estimates are that 1.2 million, or 16% of adults that live in the border region, have type 2 diabetes, and this percentage of 16% among adults is a rate that exceeds the national levels for both the U.S. and Mexico. So approximately 700,000 adults with type 2 diabetes, or 80% of whom are of Mexican descent, live on the U.S. side of the border. My research is on the U.S. side. And about 61% of those persons who have type 2 diabetes also have one family member that also has type 2 diabetes. So you can see how prevalent it is. The ethnic disparity and the burden of diabetes among Hispanics, who are the largest minority population in the U.S., is clear when you compare them to non-Hispanic whites. Hispanics have 2 to 3 times greater the prevalence of diabetes and premature death from cardiovascular events. Mexican Americans have an increased risk and prevalence of diabetes-related complications and a higher disability rate when you compare them with non-Hispanic whites. So you can see why the U.S.-Mexico border region is a unique geopolitical region that should be targeted for eliminating health disparities among persons of Mexican origin. And the family is really important in influencing Mexican Americans' health-seeking behaviors and facilitating individual and social change. But what's interesting is that traditional diabetes self-management education programs are individual-oriented, and they've not capitalized on the role of family in diabetes management. As a matter of fact, 56% of persons in the U.S. ever attend a diabetes self-management education class. And among those, the rate of those who have not attended the class is even higher for persons of Mexican origin. And we know that if you attend a diabetes self-management education class, it decreases your risk of complications because you develop a skill set, the knowledge, and the support for how to manage your diabetes and hopefully to prevent downstream complications. So we have this unique approach for reducing type 2 diabetes health inequities, and that's to apply principles of community-based participatory research in the context of family. And so what we propose is culturally tailoring and then testing a diabetes self-management education program. So the goals of our research are to reduce health disparities among Mexican American adults with type 2 diabetes by improving and sustaining diabetes self-management behaviors and increasing family social support for type 2 diabetes management. We have 3 specific aims. The first is to refine a culturally tailored family member type 2 diabetes self-management social support intervention using community-based participatory research principles in a family setting. And our second aim is to test the effects of the 6-month culturally tailored intervention on behavioral and biological outcomes with Mexican American adults who have type 2 diabetes. Our first hypothesis is that those that participate in the intervention will have significant improvements in those behavioral and biological outcomes. Our third research aim is to test then the effects of this CBPR, family-tailored diabetes self-management education and social support intervention, on family social capital with Mexican American adults who have type 2 diabetes with their family member. And then, of course, our hypothesis for this aim is that those that participate in the intervention will significantly increase family social capital outcomes, health literacy, and healthcare access when compared to the waitlist control group. So as I said, we're in year 3. We've had 4 cohorts so far of Mexican-American adults with their family members that we've tested the intervention. It's a promotora-driven, lay health worker-driven intervention and with a certified diabetes educator. They're both bilingual, bicultural, from the community that in the U.S.-Mexico border region that the study is being conducted. The certified diabetes educator helped to assure that the educational component of the intervention was drawing from the American Association of Diabetes Educator curriculum. And then with our team and in phase 1, using CBPR principles, we worked with a group of 24 individuals, 12 who had diabetes and the other 12 were their family members, and they helped us to culturally tailor our previously tested individual level intervention. They helped us culturally tailor it to the context of family. And that's what we're testing now in phase 2. And as I said, we're in cohort 4. The certified diabetes educator does the education classes. The promotora facilitates the social support sessions with the diabetes educator present in the event that there's questions specific to management. And then those are the first 2 intervention components. The third intervention component are home visits, and we've manualized the intervention. The promotora delivers 3 home visits to our participants and their family member, and those home visits are specific to diabetes management challenges that we know from in this population, that we know from the literature and from our previous research and others that have been conducted in the border region with this population. So the first home visit is about eating healthy, where the promotora sits at the kitchen table, reviews with them the food labels of the food that they're eating that's right there in their kitchen, in their refrigerator, goes over portion control, all of this of which has been taught at group level by the diabetes educator, but now it's been tailored to the level of family. And for the home visits, we not only have family members, they're one family member that's in the study with them, but there may be other family members, their friends, their neighbors, whomever. We ask them to invite whomever has the greatest influence on their ability to successfully manage their diabetes. So first home visit is healthy eating, second is physical activity. We use the CDC walkability scale so that they can get out and look at their community and identify where safe walking routes are, where they might be able to walk their bike. The promotora gives them additional referrals for where they might be able to go right there in their community for reduced rates, such as joining a Pueblo neighborhood center or places like that. And then the third home visit is about managing stress, because stress, diabetes related to stress, is a major challenge for persons with diabetes and with this population specifically, because when you look at all of the other challenges they have in their life in terms of managing their diabetes, it becomes complicated quite quickly. So that's the third intervention component. The final intervention component is the telephone, and that is also delivered by the promotora. Those are brief telephone calls following up with those 3 home visits, helping them with their goals, working with family, how are they doing, any challenges that have come up, and helping them with problem solving. Then, of course, we leave them alone for 6 months, and then we do our final data collection at time 3 to look at the impact of their sustainability of the intervention. And that's what we're doing at the University of Arizona, and working and contributing toward decreasing diabetes health disparities among persons of Mexican origin and their family. Thank you.